about some of the controls that kidney has. Kidney's kind of interesting in that regard. So let us begin. So let me just organize the PowerPoint situation because it's the one we use anyway. And I'm more familiar with that than the exam crackers, which is never great unless we all had the book in front of us. Okay, so bingo. So we want to take a close look see here. This is a better representation of the proximity. Well, illustrations they pull everything out so you can see proximal convoluted and distal convoluted. But the reality is that they are all very close to one another. And so there's a lot of signals that come from adjacent structures. So each one of these doesn't matter whether it's medullary or cortical has one of these juxtaglomerular complexes, just meaning next to. And so typically it's the ascending limb of the nephron loop, and so, and depending, and maybe one or the other arterial. And basically we are dealing with two types of sensors. We're dealing with pressure sensors and we're dealing with salt sensors, osmolar sensors. And this is the area where we see a lot of inherent auto adjustment that occurs in the kidney. The other one has to do with pressure coming through the arterioles. So the kidneys, for the most part, when you look at, and we will go over it again, but the big number when it comes to blood pressure, and blood pressure impacts kidneys dramatically, because kidneys are a high pressure filter. It has to have high blood pressure. When you go into shock, your blood pressure gets low, your kidneys stop working, and they shut down. That's effectively what happens. So as long as it's called the mean arterial pressure. So you might recall it, if we look at 120 over 80, the classic numbers for the typical adult, you divide the difference is 40, you divide it by 3, and then you add that 3, which would be 13.3 approximately, to the 80, and you would have a mean arterial pressure, the average pressure in the artery, of about 93.3. As long as your kidney is somewhere between, look at the range, 80 to 180, it basically takes care of itself. So it has to be very, very low. So if you get somebody who's in shock, very often their palpable systolic pressure, which is they're in big trouble, is between like 80 and 100. Their kidneys start to fail. I have this on good authority because it happened to me back in 2006. So from salmonella poisoning. So this is the area. So you have three different portions. We looked at this anatomically. We'll look at it both ways. Macula densa. Macula, again, don't get it confused with the idea up in the macula lutea up in the eye. So watch out for words matter in this particular instance. Closely packed cells of the ascending limb. And understand when it comes up through there, we've had basically modifications in water and salt pattern, where to some extent we're concentrating the urine. So they're going to sense the salt content. Then in the arterial, whether it's afferent or efferent, you have what are called juxtaglomerular cells, JG cells. They have secrete little granules, and they're mechanical receptors to sense blood pressure that's within that arterial. Now, how much pressure is going out? And there's the chemical renin, and that generates this very famous renin angiotensin aldosterone mechanism. And effectively, there's a connector between the two called mesangial cells. To me, they're just passing signals. They're messaging cells. Undoubtedly, how they got their name. So this is a close lookup that you can see here. Here you can see the granular or JG cells. Here you can see the macula densa, which are osmosensors, and here you can see the connectors. And you can see the junction between, and you always know that the afferent is always by definition wider than the efferent arterial. And this is the critical place for auto control of flow in. If the urine is still if the urine is too concentrated, well, then we're going to have to retain a little bit more water to balance it out. That's there. If the pressure is too high or too low, if the pressure going out is too high, then we'll probably have to lose a little bit more water. And again, the more you open up this, Okay, or if you can close this a little bit, it forces more blood in here, and the longer the blood is in here, the more filtrate, and the more filtrate, the more fluid is going to be excreted. So you can do this to either retain water, limit the flow, or expedite the flow, okay, of fluid that's in there. And you can see a lot of this. And they talk about all the things it is, and the urine, and 1% of the filtrate, and the three things I talked about before: filtration, reabsorption, and secretion. And you can look at this as much as you want. And this is more anatomical than anything else. Very, very good looks, and we all did this in anatomy. So the pressure idea of the high pressure pump. And so remember, anatomically, those arteries, the renals, are disproportionately wider than, say, the gonadals below them or the suprarenals above them. And so the pressure is quite high compared to otherwise entering, it's more than double. Okay. And so the efferent arterial, the outgoing one, has a lot of resistance as well. So, I mean, we can maintain that high pressure. And then if you run the numbers, we're more likely to run them in class, but if you run the numbers, basically you can look at, this is the force that's pushing fluid out, this is the forces that's holding it in. Whatever within the Bowman's capsule, there's a certain amount of fluid, pushes fluid back in. And very famously, the proteins that don't leave there because they're too large create colloid osmotic pressure. And so effectively your net force pushing it out is about 10 millimeters of mercury. So as soon as that starts to fall below that, the kidneys don't get flow. If the kidneys don't get flow, if kidneys have one response to adversity, they shut down. Infection, damage, trauma, shut down. Shock, shut down. That's what happened to me. The next thing you know, kidneys aren't working and you're in trouble. For me, that was a one-way, fortunately not a one-way, but an immediate ticket to intensive care for 3 days. Not a pleasure. So there's the illustrations you can see there. This is another number to be familiar with, GFR. Nowadays, you might remember me showing you some of my blood tests from various measures in your chemistry profiles, your basic metabolic profile, which is typically what they do. If you go for a physical or you're admitting a patient, you'll do a complete blood count, you'll do a basic metabolic profile, BMP, whatever they do. We used to do Chem 24s, and it gives you electrolytes and BUN and glucose and creatinine, all of those measures, proteins, globulins, etc. They take from those chemistries, they have a formula to estimate glomerular filtration rate. And so, and it would be printed at the bottom of the printout. And it basically suggests to you when the numbers reach certain areas, you might have to be concerned. And again, blood tests are a snapshot. So typically and routinely, if we get one abnormal set of numbers, we'll kind of, sort of address it in a limited fashion rather than going crazy and maybe redo the test a week or two later or a month later. So we're looking at this, and these are all the factors that involve the pressure, the surface area, how permeable things are. This can be calculated, as you will see toward the end, not just by doing this estimation. In the old days, we used to collect 24-hour urines, okay, and we would use that because a lot of things, to get enough to assay something in the urine, you had to collect a lot of urine to do that. So when they used to do this, they used a plant sugar called inulin, not insulin, but inulin. And the inulin is neither absorbed or secreted. It basically is a sugar that goes through you, and as much as you put in, you put out. So you give them a trial load and measure how rapidly it goes out. And if it's at the appropriate level that it's supposed to be, then that's how you would measure it by collecting 24-hour urines and measuring the amount of inulin that was in the urine. You could make the calculation. So, and that is keeping this constant. And now we get to the physiology of the controls. So they maintain that. So, and it's all about systemic blood pressure increase Filtration causes increased urine output, which lowers blood pressure and vice versa. So the whole idea between the nervous system and the endocrine system is to maintain these levels. So most of it's auto-regulated, what I was saying before. As long as it's been that MAP range of 80 to 180, when it gets too low, like in severe shock, or too high, which is called malignant hypertension. You don't see a lot of that. When we see somebody come into the ER, back in the day, and this is only, don't even ask me, 45 years ago, we would have to put a drip of something that would immediately lower the blood pressure. I'm sure the things were different, but it was an incipient stroke. They were going to stroke out. So, so you have different kinds of mechanisms that affect on the muscles and on different kinds of feedback. So smooth muscle contracts. So increased blood pressure stretches, and what do muscles do when they're stretched? They contract reflexly. So when stretched too much, they'll limit the flow into the glomerulus. It's protective. Okay. And so by the same time, if the blood pressure goes low, okay, then those incoming arterioles will widen. That is there. So it will increase the amount of blood flow. So it helps to maintain it. The feedback depends again on the response to salt. Okay. If the rate is going up, filtrate flow increases, decreased reabsorption time, and what happens is the faster it goes through, it doesn't allow urine to be produced. Okay, and it doesn't allow it to be reabsorbed. So at that point, the incoming arterial is involved, more time for the sodium chloride to be reabsorbed. So we're allowing the urine to stay in the system. That's there. So that's just examples. So we have nerve and hormonal aspects of it as well. Sympathetic nervous system is the major override. That's fight or flight. It controls it when it's activated. So normally they're dilated and everything is auto-regulated. But if pressure goes low, such as what happened to me, you're going to get and this is the tragedy of shock, is your body it doesn't know why it's happening, that you have an infection. All it knows is your kidneys aren't working, and so what it's going to do is tries to accelerate the system. So all of a sudden, the classic presentation of shock is low blood pressure but a very high pulse rate, and your heart working overtime. That's a recipe for disaster. I mean, your heart's trying to do something that it can't physically do. It can't force blood around when there's not enough fluid in the system to force it around, except it doesn't know that. And that's the problem that's associated with it. So increases blood pressure, constricts the afferent arterioles, holding off on the amount of filtrations going in. We're trying to retain fluid in the system. That's unless there's some other mitigating factor. And then we get to this, which you do have to know. The renin-angiotensin-aldosterone mechanism. It is interesting because of what it does. And so it's one of those must understand kind of mechanisms that we look at. And it starts with this. So you can look at the thing, and there's different pathways. Okay, so it can be sympathetic, will cause this, just like we were talking about before. The macula densa cells, when the salt concentration is low, okay, or those granular cells are not getting stretched enough. All of those suggest there's oriented toward blood pressure problems. Here's the events that occur. So when any of those things effectively occur, and effectively they're all signs of blood pressure dropping, renin is released. Renin then goes through the blood, and you have a compound. It's not in the kidneys, it's in the bloodstream. So this is released into the bloodstream, called angiotensinogen. Angiotensinogen. Again, ogen, as you'll see repetitively in physiology, is a precursor hormone. It has to be activated. We're going to see this shortly when we start talking about blood. Very soon, we'll undoubtedly be doing that on Friday in physiology. That converts it to a compound called angiotensin 1. that has some activity. Then in the lungs, there's an enzyme called ACE, which stands for angiotensin converting enzyme. And what that does is it converts it to the active form angiotensin 2. Angiotensin 2 then will work on the adrenal glands to release aldosterone. Okay. But angiotensin 2 will also increase thirst. It will cause an increased secretion of antidiuretic hormone, and it'll do what its name says. It will tighten blood vessels, angiotensin, tensing the blood vessels. And when you tighten blood vessels, it directly elevates blood pressure. And the aldosterone, perhaps most importantly, and it's always being done. These are subtle adjustments done continuously based on the kidney to a certain extent. Aldosterone will insert into the distal convoluted tubule and collecting ducts little openings for sodium to be pulled out of the urine. Dare I say it again? What happens when sodium goes someplace? Mary, the water. It's like one shepherd said to the other shepherd, let's get the flock out of here. You remember that one. So you can take a look at all of these mechanisms, what they do. Here it is. Renin, eventually making angiotensin 2. Aldosterone and interestingly, this is a pathway that is constantly used for blood pressure control. We use two major weapons, both of which I happen to take. Okay, one weapon is basically a calcium channel blocker, which works more on smooth muscles and to a heart to a certain extent to limit extracellular calcium coming in. And the other one, and there's any number of them that impact this system. The one I take is called losartan or Cozar. It's not quite I used to take an ACE inhibitor. They have a little more side effects. So there's variants that are there with regard to it. So here you can see aldosterone from the adrenal cortex, sodium with water, increasing blood volume, vasoconstriction, thirst, antidiuretic hormone. Other things, okay, adenosine and various kinds of prostaglandins, they work locally, okay, and other things that occur. So again, we begin to see that adenosine is something that when you're drinking caffeinated beverages plays a role. Caffeine blocks adenosine receptors in the app, so adenosine can typically relaxes the system or limits it. So there's a number of things like this, and these are the numbers. When somebody's only putting out less than 50 mil, less than 2 ounces of urine a day, that's they're in trouble. Too low to cause filtration, various situations that occur with a sort of inflammation, obviously significant. Transfusion, that's one of those critical areas. It's a real problem. When we get incompatible transfusions, the kidney, large lumps. Remember when we did the blood, and we're going to do the blood lab, and we did it before. When you do blood testing, you do a process called agglutination to see if they're compatible or incompatible, to see if you're A positive, B negative, whatever the heck you are. And those clumps magnify themselves in transfusion in the kidney, and so the kidney is the one that's the most rapidly failed organ. That's very significant. So done with that. Happy to. See you later. Next one. Okay. So, and now this is sort of looking at some of the specifics about what happens with resorption. So the first thing to understand, Nearly 2/3 of all the resorption and a great deal of the secretion occurs in the proximal convoluted tubule. Before it gets to that nephron loop, business is almost all done. That's there. So as you can see, organic nutrients, okay, resorbed, water and ion resorption is hormonally regulated and adjustive. We have active and we have passive. It can go through the cells, it can go next to the cells. There's a lot of variations that are there. Okay. So, and there's, and again, that's not something MCAT wise. So, between the cells, limited by type junctions, but leaky in the proximal area of the nephron. So, you can see water, calcium, magnesium, potassium, some sodium in the proximal convoluted tubule move via this route. So, there's a little bit, and so those are kind of like little leak channels, but not within the cell membrane, but between adjacent cells that are there, is what they're talking about paracellular. And they just show you some of these things that are through that. Sodium certainly is the big player, and now we get to that thing that's sort of a reinforcement, which you learned a while ago, primary active transport. Okay, so typically you move sodium, okay, and transport of sodium across the basal membrane of tubular cells by primary active transport, and then if we're pumping it into the interstitial space, then we can utilize the sodium potassium pumps. Okay. What's interesting about that, then we have secondary routes. So when sodium moves in, it really creates a secondary active co-transport or symport type of thing. And glucose is the big player in this, by the way. So active pumping at the membrane results in the gradient, okay, facilitates sodium diffusion, okay. And so typically, again, you're going to see sodium and potassium moving oppositely. Okay. And so secondary. So however they're going to move it, but glucose, amino acids, vitamins, certain kinds of charged particles, sodium is the big player. That's why sodium play is such an important to look at. Fortunately, it's rare to see irregularity in sodium levels. It is not in potassium levels. Okay. And so again, not just sodium, but a lot of other factors, even though sodium is the principal reason that water moves. So there's lots of water that's there. So they're always present. Water pores are always present in the proximal convoluted tubule. But what happens, water pores in the presence of antidiuretic hormone, like over here, when we release that, it inserts them into the collecting tubes and sometimes even into the distal convoluted tubule. So those facultative water resorption or the aldosterone-based sodium and then water reabsorption are more things that are they're think of them as final adjustments that are not necessarily always present or always extraordinarily active. There's always going to be some aldosterone working, but it turned. If you're dehydrated for any reason, that system gets bumped up to a certain extent into a greater degree of overdrive. It's such a complex area. I can anecdotally, I remember I'm doing this rotation as a student, and one of the attendings, my attending was a diabetologist, which is great for me. The other attending was a nephrologist, and I can recall one of these. These weren't students; these were young doctors who were already in either internship or residency. And we didn't have anything like we have today. It was good old blackboards, and he's sitting there writing stuff on the blackboard, layers and layers, and sitting back and trying to analyze all the findings. That's the complexity and these were very, very sharp people. I'm like, wow, really? That's the complexity. Kidney's hard. He said cardiology, nephrology, diabetology, pathology. It's what I like to call doctors. The smart doctors go there. It's true. Not everybody's brilliant. Somebody has to be at the bottom of the class. We were in an era where there was a certain degree of counterculture. So a lot of schools, Ivy League schools, went to pass fail. and some had pass, high pass, and fail. To me, that's just great. It's A, C, or F. That's up. We were strictly pass fail. So how do you distinguish between somebody who? So there had to be other means that would do that. So for us, it was board examinations and various things that you did, honor societies and stuff like that, that sort of separated you in the bar, but mostly board examinations of that type of stuff. Whether, so it kind of does this, that if that's not in vogue, it'll come back in vogue. We used to be able to go to college and say, I'd like to take this course pass fail. And if you got permission, you did. So what happens is solute concentration in the filter increases, water is reabsorbed, and so that creates a gradient. So some of these things will follow water into the peritubular capillaries that are there, even fat-soluble substances. One of the problems, lipid-soluble drugs and environmental pollutants are resorbed, even though it's not desirable. That's a big problem. Fat-soluble substances tend to stay with you longer, okay? And so the kidneys aren't nearly as efficient in dealing with certain things that you would like them to deal with. The side note to that is why lipid-soluble agents, when we did a lot of drug testing, were something you had to be really cautious about, because they could, a water-soluble agent vis-a-vis cocaine, you drug test people randomly 3 or 4 times a week because it's gone in 2 days. Marijuana is not. It's more in the fat soluble. That's all something we learned in our age. But I don't know why. Don't look at me. Don't judge me. Now I have to make reservations on Southwest to go on spring break. Going to Jacksonville. See my kids, my grandkids. My wife, yeah, we're looking forward to it. And I said, but years ago we didn't. We just put a poster up of Jacksonville and you could travel anywhere you wanted. You never have to move. Just saying.
You love that joke.
What?
You love that
I do love that joke. But it's true. It's true. There were a lot of, the statute of limitation has expired, hallucinogenic substances that were abundant. Guys just are not having fun. Okay. Transport maximums. You heard it. You guys are going to hear it again in diabetes. The single most important thing I can tell you are transport maximums. So when you overload these carriers, okay, they lose efficiency. Once you overload them, they can't move anything else. And when you overload them, and this is why in diabetes we measure it originally before the age of glucometers by spillage into the urine. And the problem was it damaged the carriers when they were continually saturated and effectively lowered their ability to excrete sugars efficiently. That is a major issue. Be aware of that. So 65% of sodium in water, proximal convoluted tubule, whole bunch of stuff. Notice urea, which you don't want to retain, other than a relatively small amount, you bring in to be able to create a gradient to secrete it later. The loop, again, descending limb water can move, ascending, we've covered this before, thin and thick segments. The thick segments involve sodium, potassium, and chloride, symporters, and sodium and hydrogen antiporters, so you can move these in different directions. Distal reabsorption is hormonally regulated. Antidiuretic hormone, collecting ducts to insert the aquaporins, increasing water, aldosterone, collecting ducts mostly, distal and the distal convoluted tubule, synthesis of certain types of channels. You don't have to go into the detail. So we're able to retain it with the absence of aldosterone. Someone had a faulty adrenal gland mechanism. you would be continuously losing sodium and you couldn't survive. And again, that is able to maintain good levels of potassium because potassium can be either too high or too low. The flip side of that, from a hormonal standpoint, is ANP. We'll look at that in endocrine again. Atrial natriuretic peptide. And what that means is when the atrium is stretched, it sends a signal to fight aldosterone and release sodium to a certain extent. Okay, and in parathyroid hormone, that's different. And we're going to be looking at that in endocrine for those of you in phys class. It's there, and it's a nice little chart that you can kind of glance at to do there. Secretion is the reverse. Okay, so two is reabsorbs reverse. It's almost all done again. Proximal convoluted tubules. Okay, nearly all the stuff that we have to get rid of. So it's basically done early. To me, even though we see more secretion proportionally in the distal, on an overall basis, everything's in the proximal convoluted tubule. The distal is kind of like the final adjustment. Think of it this way: final adjustment of the urine, final adjustment of sodium and water. Okay, so drugs and metabolites, undesirable substances, excess potassium, that's associated with, again, aldosterone moves sodium in, potassium out. And that's one of the difficult things for years with diuretics, was excessively lowering. When we're moving the fluid, we were lowering potassium, and potassium levels, typically you're doing people with faulty hearts, and those potassium levels will then set the stage for arrhythmias. I was always worried about that with my dad back in the day, like that, because I knew he was on digitalis and diuretics, but that's all they had. That type of thing. I mean, I couldn't account for the other events that affected his heart so adversely. Was there? I gotta get my sister to send me a picture of my dad when he was in the Coast Guard in World War II, and my mom when they were either just married or just engaged. Wow. Jet black hair, mustache, sturdy. My sister has those all in her possession. Okay, so the whole idea, this is roughly normal for us, 300 milliosmoles. That's typical osmotic concentration. So I don't care about it. You should know that between osmolarity and osmolality. Osmolality is per weight, osmolarity is per volume. I don't want to do that. That's chemistry. Fuck the badger. So here's the countercurrent mechanisms. Two aspects of it: the multiplier and the exchanger. The multiplier is just that. Basically, you're going to see as we get farther down into the again, this develops in infancy, and finally, by roughly age 3 or 4, we begin to develop the adult model, where there's increasing amounts of concentration as we get deeper into the kidney, more central than peripheral. So as we get deeper into the medulla, approaching those calyces that you would remember, at the tip of the pyramids, the apex of the pyramids, that's where it's highly concentrated. And that's all well and good for moving water and a certain amount of solute out, but we need the exchanger to take that material and put them back into the bloodstream. Okay, and so the gradients run from within this. Understand when we get out of it into, if 300 is basically isotonic, urine is somewhat hypotonic. So that effectively, we even are putting a greater amount of water out in that, comparatively speaking. So the multiplier creates the gradient, the exchanger preserves it. Easy way to look at it. And so, and there's variation, so we can use this in varying urine concentrations. Just like if you're outside, if you're working out or go to the gym, you're working outside on a hot day, that type of stuff changes. So here, look at it. Out here in the cortical area, effectively normal as you get down to the tip, substantially more concentrated wherever you're looking. And the whole idea of the way these things work is with regard to the flow of it itself, as you're beginning to get flow going here and flow going here, you have those hairpin turns that allow it to reverse relatively quickly. So that's the anatomical basis of this. And so they just basically, this is the part you have to know without going into the gory details about it. So the multiplier, filtrate flow in opposite directions, down and then up. Permeabilities, water permeable going down, solute permeable going up, water impermeable. And we have to use active transports in the ascending limb because it's thick. It's not a membrane they can get through. So are not in direct contact, but are close enough to influence each other with exchanges with surrounding interstitial fluid. So it's that hairpin turn in the proximity that really allows the gradient to impact what's going on. And so they're just reiterating what I've stated before. So the descending limb is freely permeable to water and permeable to solids, and the opposite. So as water passes out, now we're getting to roughly that 1200 milliosmoles, which is compatible with where it's located at the apex or the tip of the pyramid. Okay. The more salt the ascending limb actively transports out, the more water diffuses out in the descending limb. So it's being pulled out there, it impacts water coming out on the opposite side. So there's always a constant difference between the two limbs of about 200 milliosmoles. That's a question that you might be asked, and it's multiplied along the length that's there between the 300 and 900. So and you can go through that as easily as I can, but notice what's happening. So you always have that 200, 200, 200, 200 until you get finally down to the bottom of the loop. It's there. The exchanger, those long sort of draped capillaries, the vasa recta, very permeable to both. Countercurrent as well, so blood can exchange salt and water with surrounding interstitial fluid as it moves through those adjacent parallel sections. That's stated better than I could state it. So effectively, the bloodstream, it doesn't change its isoosmotic nature that's there. So because it can absorb both the water and the solutes that are in there. So it preserves the gradient. It's there. And so what they're saying at the end, water in the ascending vasa recta comes from descending vasa recta or is reabsorbed from the nephron loop and the collecting duct. As a result, the volume at the end of the blood in the vasa recta is greater than in the beginning. So effectively, if everything is working properly, think of what's happened. That blood that was going through that capillary beds, comparatively speaking, does not have enough total fluid basis. It's being maintained. It's not destroying the red cells or the proteins, but it requires, by the time it leaves that system, it's going to need to absorb more water to make it hypotonic and to accomplish what the kidneys are supposed to do, retain fluid. Because whether it's the juxtamedullary glomeruli or the cortical ones, which are much more juxtamedullary about water and salt, the other ones are about all those myriad of solutes, acids and glucose and amino acids and all of the different things that are there. In order for that to truly occur properly, we have to bring that blood back and restore the fluid so that blood will flow easily into eventually the renal veins and back into the inferior vena cava and back to the heart. So you got to do that. So without the gradient, we'd not be able to raise urine concentration, overhydration, and then we compensate with whether we have different things. Okay, antidiuretic decreases it, aldosterone can pull back in, etc. All of those types of things we looked at before. So they give you some numbers, and we don't have to go through a whole lot. And obviously, it's different environmentally where your environment is, as opposed to where it is if you were, I'd be jogging in the desert. So ridiculous. We were in Joshua Tree's desert. Oh my God! In the summer, God, it was 112 to 150. I mean, you could barely. And it's like a mountainous desert out there when you're near Palm Springs. Those are mountain deserts or your high low. Oh my God! We had I I was driving. We must have had 10 gallons of water just in case we got stuck. Because you drive in from the highway, you're 30 miles in. Oh my God! Jog. I couldn't walk. My wife's kids are climbing up the rocks. Oh, that's crazy. Urea plays a role in the gradient as well. This is what diuretics do. Basically, they inhibit ADH, that's alcohol. There's different ones that are there. Okay. So, caffeine or drugs for hypertension or edema can also, they can inhibit it. So, there's a certain amount that, they sort of indirectly act as diuretics. These are osmotic diuretics that sometimes you'll try to utilize in a hospital sense to pull things. And we're just about done with all this. So again, the big deal is nitrogenous wastes. You get a quick snapshot to know that the kidney's doing what it's supposed to do with the appropriate nitrogenous waste. And so this is what they talk about vis-a-vis the physics behind it. This is the plant polysaccharide. And so it effectively, whatever the trial load is, you know the amount of time you collect the urine for 24 hours. So when someone has kidneys that are, quote, failing, if they have below half of the normal rate for 3 months, the filtrate formation decreases, nitrogenous wastes accumulate. It leads to a degree of acidosis. We see this certainly in hypertension because of damage to the blood vessels. Diabetes is unique because, particularly insulin dependent, has an autoimmune component where large lumps of proteins settle out in the kidney. And those proteins are antigen antibody complexes, only happen in autoimmune phenomena, and they're nasty. We used to have a name for it. It was a combination of edema, hypertension, and diabetes. The syndrome was called KW, was still for Kimmel-Style-Wilson disease. We didn't know about the autoimmune component. We just knew it existed because when they examined kidneys post-mortem or post-removal for transplantation, they saw these big lumps in diabetics and went, what is this? And so when it gets below there, now you're in renal failure. That's uremic poisoning. Those nitrogenous wastes. Urea in the bloodstream just is a tremendous toxin, highlighted not just by fatigue or anorexia, but mental changes particularly. And there's a tell down the road. Itchy. And again, I have a certain amount of first-hand knowledge. My grandfather, my dad's dad, died when he was 86. Just good lifespan. He had lost a kidney because of an antibiotic that caused crystallization. I was told. I never know what the truth is. Parents were like that. I didn't know my grandmother was my step-grandmother until I was 18. They didn't tell you freaking anything. Okay. And he had lost it in the 40s or 50s. And so he had one kidney, and that kidney eventually failed. And that was the cause of really the cause of his death. Obviously, it was a long time. But the itchiness was there. And then when he was in the hospital, his behavior was totally different. Totally different. He was a remarkable man, too. So, and then you can take a look at what this is. So again, the urea is uric acid against purines, urea, all about amino acids. Creatinine from the agent we use for muscle activity, all the other things that are there that are important. These are the things you look at. That's why if you have a freestanding type of question that says, okay, what's going on here? So, most likely diabetes. Proteins. It doesn't necessarily mean anything. It could be pregnancy, physical exertion, but if there's a larger amount, then you're starting to look for damage in the kidney or other signs. Ketones, okay? Starvation, untreated diabetes would generate ketosis, which is a big problem. Ketone bodies slam into each other, cause trans fats that are nasty. Or if you're doing what I'm doing now on a ketosis diet, a keto diet, you want that, but you want to be able to get it out. Hemoglobin, any types of things that we could see there, hemolytic anemia. Again, if you're frank blood, like I had, is almost always bladder cancer. Because normally hemoglobin is something you tell dipstick wise or discoloration. Bile, okay, hematuria, again, those are that's the one I had, unfortunately. It could be any of these. And urinary tract infection because it's pus. And then they give you the same thing. The urochrome, what gives it its characteristic color, again, is really something called urobilinogen, which is a breakdown product. Hemoglobin colors urine and feces. It's breakdown products as we get rid of it. And that's it. There's not a whole lot to say here. Okay. More anatomical than physiological. It doesn't do a lot of physiology unless you're stupid like me and smoke, and then you get cancer. Goodbye. We're done. Moral of the story is don't smoke.